So, lung ultrasound is about artifacts. So the first thing you have to know is you have to take off all the smart buttons. You have to put your machine back to being basic and primitive, which means we want to do the opposite to what you're taught. We want to put the focus up high in the top of the screen, and we want to put the depth down low to 12 or 15 centimeters technically. We want a very grainy picture, which is why we tend to have a low dynamic range, not too many shades of grey, only 20 compared to 50. And we don't want the fancy multi-beam or sono CT because or multi-beam or cross-res, we don't want that. We want back to raw images. There are many protocols. The protocols that I use for an adult use a curved abdominal probe oriented in longitudinal. There are three main protocols, I guess you could say. There's the quick and dirty, very rapid 2-point probe in the hot spots where you're just looking one view each side, looking for either wet, which is B lines, or dry, which is the horizontal A lines. And that particular view of the hot spots is just in the anterior axillary fold where we're looking for a rib and a rib, then we look at that bright white line between it, a tiny bit of rocking side to side till it is as sharp as possible, and then there we actually have one, almost a B line down there. One is fine. It's when you get three or more that you start to diagnose pathology. So there I've saved one. Now if Jan was very short of breath on an ambulance stretcher and I want to know whether she's got COPD or whether she's got asthma, this is all I have to do, because if she has asthma we'll have a picture like this with the horizontals, and if she has pulmonary edema she'll have all the verticals, both sides. That's what we call the 2-point protocol just for hot spots. That's when you don't have any time at all. When you have a couple of minutes, then what you're looking at is an 8-point protocol, 4 on the right and 4 on the left. So what we do is we start in the mid-clavicular line, zone 1 according to the International Consensus Guidelines. Zone 2 is here, mid-clavicular line but lower. Zone 3 is up high in the axilla but it's behind the anterior axillary line, and zone 4 is just in front of the posterior axillary line, but as far laterobasally as you can get. On the 8-view protocol you're not interrogating the posterior basis, so you don't rule out posterior pneumonias, but you usually get a hint for it. Press the probe on the top. Here we have the subclavian vessels, we have the lung diving down under the clavicle. That's our first zone. Sometimes you just rock a little bit side to side, see if there's anything interesting to get. Yeah, we've got a bit of a sub-B line, 1 is fine. And you just freeze it. I would label it R1. Is that label? Oh well. No, never mind. Oh yeah, there it is. Yep, freeze capture. And then I would move down directly until I find the bottom of the lung, and it runs into the liver. Now this is the middle lobe here, and we can see the rib, and we can see again the lung here. We want at least one rib in the picture because the rib orientates people to exactly where the pleural line is. The pleural line is 5 millimeters below the leading edge of the rib, and you must watch to see that it actually moves. If it didn't move, if it looks still like that, that's what a pneumothorax would look like. It might heave with respiration, but you don't have that separate sliding movement. So sliding is something you should always look for in every view. So that I would label as R2. Oops, if I hit the annotate button first. I have the Baker School of Cumulative Labelling, which means I don't even bother taking off the previous labels. You're lucky to get an emergency physician to label anything. So we hope we saved that one. Then we move as high in the axilla as you can, but just behind the anterior axillary fold. Now, I don't like people putting their arm up here because that distorts the axillary fold and actually makes it a bit harder. So I like having the arm out at about 45 degrees because that keeps the anterior axillary fold just nicely, and you can sneak in just behind it. Now here, the ribs tend to come at a very sharp angle down, and so at this point you may need to either rotate clockwise to get some more ribs in the picture, or anti-clockwise if you want to get rid of some ribs. Now, oh, isn't that beautiful? You can actually probably see the fissure between the upper lobe and the lower lobe just in there. You can see that tiny little gap where there's two separate bits of lungs. Oh, what a find that is. And you almost see them moving just slightly asynchronously if you were close like me. So I would label that R3, and again, it's quite normal. Capture it and move on. And then the last view on this side, and this is the one that people tend to get wrong because they don't tend to go posteriorly enough. People like Liechtenstein, who works in intensive care, often doesn't bother with this one. There was an argument to say why bother, because there's usually some B-lines down here. But I like it because I think it's really important to see whether we have any tiny bit of effusion down there behind the diaphragm. I like to see that the diaphragm is working and moving, and I like to see the very lowermost point of the lung, because if you have any scarring you'll often see a knobble or smooth bit there. So this view I like to get. So watch, big breath, Jan. Yes, the lung, and breathe out. I like to see the lung curtain move all the way across and occlude the liver. You can see it going forwards and backwards, and that's the very lowermost point of the lung, posterobasally. So I'd save that one. Now, in the 8-point scanning protocol, which is one of the approved, agreed upon ones, you then just do the same on the other side. And what you're looking for is if you get 3 B lines or more in two separate views on 2 separate sides, then you have evidence for acute pulmonary edema in a breathless older person. Now, this same protocol is no good in a young person in the middle of a flu epidemic, because 2 by 2 by 3, 12 B lines, is far more likely to be a sign of the flu, a pneumonitis. But in a group that is prone to APO, the breathless older patient, this sort of 3 B lines, 2 different spaces on 2 different sides, it's got about depending on which group you read, anything from 85 to 95% sensitivity specificity for pulmonary edema, and it depends a little bit on who you exclude. So that was 2. Now here on this side, the arm at 45 degrees just behind the anterior axillary line. Now when you lean across a patient, you tend to get, unfortunately without intending to, you may get different angles. So when you're here, it's easy to point and get it right, but when you lean across, you forget that you have to point back towards the mediastinum. Here, you have to point in towards yourself, and you keep wiggling the probe until that line is very sharp. And then here, when we're really posterobasally, I like to go down and make sure I've actually found the spleen and come back up again. It's quite easy to find the stomach and think that you have found a pneumonia. So something like that is what a pneumonia looks like, but that's below the diaphragm. So I like to purposely identify the kidney, identify the spleen, find that lung curtain, watch it wash across, and make sure there's no fluid back here on the diaphragm. I want a tiny bit of diaphragm. I can't see it. Just coming in there maybe at the most. There. So there's no dark triangle there. So I'd be happy, well, probably should have got a bigger breath, but a little expanse of lung tissue there, and I've proven that there's no B lines down the base there. So that's your 8-view protocol, and you use that as a sort of a rough, quick screening that takes 2 or 3 minutes if you're looking for pulmonary edema, and it gives you a fair insight into whether there's a posterior pneumonia, but it won't pick all of them. So the last thing you have to do is look in the bases at the back of a patient. Perhaps, Jan, can I, if we leave this on, I'll get you to roll towards me. Pneumonia. Or if you have a patient in intensive care that you can't take to a CT scanner, or if you have a child that you don't want to get a dozen chest x-rays on, then you should also interrogate the back. And you have to watch out for the scapula, which of course sits there and there, and you can't see through the scapula, but we want to go down medial to the scapula. Then I like to sweep out here, just because this area here, the posterior back of the base of the lung, is a very high vascular flow, high vascular distribution. So if you get PEs, subsegmental PEs, they come down here, your pneumonias. These are the areas that you don't see well on a chest x-ray because they're behind the diaphragm. So they're the areas where I think you should scan because you pick up a bit. Cold now. Jan, you ready?
Yep.
So here again, we're just looking for the same thing. The trick with the back is that the ribs dive in to meet the spinal column. So when I put my probe on, I don't put it directly perpendicular to the skin. I actually tilt it a little bit so the beam is pointing away from the spine, believe it or not. So if I'm 90 degrees to the skin, see how unclear that is? I don't have the sharp pleural edge. But if I tilt in away from the spine, finally I get that nice clear edge. That's what I'm looking for. And I just slide down, 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 down. And you do have to be careful to follow the curve, the ribs. There we go, found the kidney. So this is the very bottom of the lung. This is the area that we dump all our little subsegmental PEs. And it's clean as a whistle. See? Lovely. There's no defects in the surface of the lung anywhere. Around there. So I'd be very happy that this lung, the surface area of this lung is very clear. X-rays will see the hilum, and ultrasound won't see the hilum. So no matter what you do, well, unless you do endobronchial ultrasound, you'll never clear someone completely. But then again, chest X-ray has its problems too. Cold again, Jan. So again, now there's directly perpendicular to the skin, so I tilt it a little bit away from the midline. There we have the nice clear pleura. It slides. I come down, down. Sometimes I go a little bit side to side because if you get very close to the midline, this is where the pleura dives in towards the ribs. You pick up a few P's there sometimes. Sometimes you can also turn transverse and you go down the dome of the lung. That's rib, which looks the same. That's lung because it moves. Rib, lung. I'm moving down. Rib, lung. Just moving down, and again, and then finally got to kidney. That's pristine. If we sweep around the back under the scapula, make sure you're 90 degrees to the lung. Beautifully clear. Beautiful. So these two zones are often called posterior, and this one may be called 5 and this one may be called 6 depending on what protocol you're going. Those are the ones that the views that you add if you want to exclude a posterior pneumonia and aspiration of loculated effusion. Thanks very much, Jan. About there. Is that okay? Thank you, Marty.